Good morning, and welcome to the second day of the British Society of Echocardiography Congress. I'm Denisa Muraro from Milan, Italy, and it is my pleasure to co-chair the first session of this day together with Dr. Catherine Towson. We will have a very interesting session dedicated to pulmonary hypertension with a great lineup of speakers. But before passing to the first presentation, I would like maybe to have the QR code? Not? No? Okay. Just scan this if you want to address your questions to the speakers and take advantage to interact and learn from their experience. So without further ado, it is my great pleasure to introduce the first speaker, Dr. Nina Karia, who will discuss about pathophysiology, diagnosis, and treatment. Please.
Thank you, BSE, for inviting me to do this talk, and well done everyone for making it after a Friday night. Now, I am going to be talking through diagnosis, pathophysiology, and treatment, and here are my disclosures. And remember, pathophysiology will run all the way through this talk because PH is all about physiology. Now, in terms of, I'll be using these terminology, and so it's important to understand the difference. So pulmonary hypertension is where you have high pressure of the pulmonary artery, but it's pulmonary arterial hypertension where you actually have vasculopathy of the vessel itself. Now, the classification through ESC is based, it classifies PH into 5 clinical classifications, and this is based on underlying pathophysiology. So you've got group 1 PAH, which is secondary to actual vasculopathy. So this is the commonest cause is idiopathic. Then you've got CTD, HRV, portal hypertension, drugs, toxin, and hereditary and congenital within this group as risk factors. And then you've got group 2 pulmonary hypertension secondary to left heart disease, group 3 pulmonary hypertension secondary to lung disease, group 4 secondary to chronic thromboembolic disease, and group 5, which is multifactorial, things such as sarcoid. Now remember, it is only group 1 and group 4 which include vasculopathy, and this is where we treat patients with pulmonary vasodilators. For group 2 and group 3, which are the most common, you treat the underlying cause. And in terms of pathophysiology of PAH, it's still being understood, but there are 3 main components. You have vascular remodeling, which you see on histology slides. You have endothelial dysfunction, and there is an imbalance in the signaling pathway. So when it comes to vascular remodeling, what we really have to understand is the difference between pre- and post-capillary pulmonary hypertension and what happens. And in pre-capillary pulmonary hypertension, what you have is you have an increase in cytokines, you therefore get an influx of cells and inflammation, and therefore you get hyperplasia, hypertrophy, and fibrosis within the vessel itself. What then tends to happen is that you lose your distal pulmonary arteries, and you see that on CT scanning where you get distal pruning of your pulmonary arteries, and this can lead to vasoconstriction. Now, ultimately, this leads to RV-PA uncoupling, and that leads to RV failure. Now, when it comes to post-capillary pulmonary hypertension, what you have is that it's much more of a passive process, secondary to high filling pressures from the left side, and that is transmitted to the PA. But eventually, over chronic changes, things can become fixed. And this is really poor prognostic sign for post-capillary patients. And you can get arterializations of the pulmonary veins. And then again, fixed changes where you can get RV-PA uncoupling and RV failure. And this is from the ESC guidelines, and what you see is the change in your pulmonary artery. You can see that in your histology slides, normal versus abnormal, where you get this vascular remodeling. And you can get plexiform formation, hypertrophy, vasoconstriction. And at the later stages of PH, it's a pro-inflammatory state, so you can get in situ fibrosis. And ultimately, what your right heart is having to face is high pressures to push against. And then you get RV remodeling and RV failure, which is what leads to death in pulmonary hypertension, in PAH. Now we're going to come over to diagnosis by right heart catheterization, and this is pure physiology. And right heart catheterization is still the gold standard when it comes to diagnosis of pulmonary hypertension. All of the other investigations we do give us clues, but they do not give us a diagnosis. But it is an invasive test, and that comes with potential risk. Now, the risks are listed below. The 3 methods in which you get access, you can go internal, jugular, brachial, and femoral. We tend to go femoral for our CTD patients because of skin tightening. And there are some safety things to try and minimize your risk, including don't pull back with the balloon inflated. Don't try to avoid inflating in your pulmonary artery and inflate your balloon in the right atrium. And this is what we perform right heart catheterization with a Swan-Ganz catheter. And it's important that what you have here is you've got 2 ports. You've got your proximal port, my pointer is not working, which is your blue port, which often is in the right atrium, and then you've got your distal port, which measures the pressures in your pulmonary artery. You've got your balloon, it's a soft catheter, and therefore it is safer, and your thermistor, which we use for thermodilution. And what's really important is getting the steps right. It's about making sure that your pressures are accurate. And so what we recommend is zeroing, where you go mid-cavity and it's in the plane of the left atrium. Now, this is a really important step because 1 millimeter of mercury does make a difference between pH and no pH, so 20, 21, between treatable pH and non-treatable pH, a mean PA pressure of 24 versus 25. So it's really important to get this right. And if something is not looking right during your right heart catheterization, it's important to recheck your zero. And so now we are in the right atrium, okay? It's important to know your normal pressures. So normal right atrial pressure is between 2 and 6 millimeters of mercury. And it's important to have your ECG gating. Now remember, this is pure physiology, the same as your JVP. So you've got your A and your V wave. Your A wave is associated with atrial contraction and therefore on your ECG is related to your P wave. And then you've got your V wave, which is at the end of your T wave, when after ventricular contraction, where your atria starts filling against your closed tricuspid valve. And then you've got your descents, your X and your Y descents, where you've got relaxation of your atria and also emptying of your atria. And it's important to know the physiology. Now, when we take a measurement for RA pressure, what we're really doing is looking at the A wave. Now, this is an example that you can see of a patient who has really high RA pressure. So if you look at the A wave, and when you've got high right atrial pressure, what happens is things equalize. It's not subject to respiratory variation because the pressure is so high. And so what you see is a plain trace which doesn't move with inspiration and expiration. And you can see here that the RA pressure is high, above 12. And what you can also see is prominent Y descents, which is often an indication of RV failure. And in terms of RA pressure, it's really important in prognostication. We know that it is associated with prognosis, and ESC classifies this in terms of hemodynamics into a low, intermediate, and high risk, with a high risk group being greater than 14 millimeters of mercury. And this is one of 3 indices we use, and MPAP is not included. So other indices include stroke volume index and cardiac index. And how does this relate back to echo? Well, actually, when we look at our estimated RAP, we know that we look at IVC size and collapse. And this comes from lots of data where echo measurements have been compared to invasive measurements, where we try and look at the most highest specificity and sensitivity. And so we know RA pressure can correlate to estimated RAP on echocardiogram, but there is a really high degree of limits of agreement. And therefore, especially at higher estimated RAP, actually you lose that sensitivity and there is less concordance. And actually you can get a variation of like -16 to +9. So that's why right heart catheterization is gold standard to get exact measurements. We are now in the right ventricle. And remember, what we look at here is your right ventricular systolic pressure, and you look at your RV-EDP. And what you can see here is that a normal systolic pressure is less than 35, and here the systolic pressure is close to 90. By this point, we already know that this patient's got pulmonary hypertension. It should be similar to your estimated pulmonary artery systolic pressure. And if you look at the RV-EDP, that should really equate to your RA pressure. And here you can see this is elevated at around 10. And so therefore, we already know that this patient has pulmonary hypertension. And remember, how does this relate back to echo? Well, this is the measurement that we use and is often reported on echo reports. So your systolic pressure is equal to your estimated PASP, and that is you use your TRV in your Bernoulli's equation, and you add the right atrial pressure. Now, any errors in measurements here will get amplified, and we know that there are inaccuracies associated with estimated RAP by IVC measurement, and therefore we've got to be careful. And remember, but it is associated with a poorer prognosis, and remember, we're looking at estimated PASP versus mean PA pressure, which is what we use for diagnosis in pulmonary hypertension. And in terms of correlations, well, it does correlate, But in just over 50%, the exact value is inaccurate, and that can be from underestimations or overestimations of greater than 10 millimeters of mercury. And again, the limits of agreements can be wide. Now, to diagnosis, we are in the pulmonary artery. Diagnosis of pH is where you have a mean PA pressure of greater than 20. And looking at the trace here, the PA pressure is much less likely to be affected by inspiratory and expiratory change. And therefore, of all of the measurements where you have to look at the actual pressure tracings, this is more likely that the calculated average is likely correct because you don't get that change with inspiration and expiration. However, the caveat to that is that you can get that with high BMIs and with severe respiratory disease. And you can see the mean PA pressure here is close to 50, so this patient has pulmonary hypertension. You can see that this is a good trace because you've got the dichrotic notch suggestive of the pulmonary vein closure. And that's important to make sure that you're not over-dampening, you're not in a small vessel to get a true mean pulmonary artery pressure. And you can do a calculation with your right heart cath, looking at your systolic pressure, diastolic pressure, and averaging that out to get your mean PA pressure. And so the diagnosis of pulmonary hypertension is with a mean PA pressure of greater than 20, and this has been a major change over the last 2 years, because historically we used a cutoff of greater than 25, which had been used for over 4 decades. And the reason for this change is because we know that normal is 14, 2 standard deviations away from that is 19, and there is a huge body of evidence to suggest that there is worsening mortality in patients who have this mild elevations in hemodynamics, and we've shown that in our UK-based study, Evidence PAH. Now, there are calculations and ways of trying to calculate that by echo, and these are the different formulas that have been put up in terms of echo measurements of mean PA pressure, where you use TRV. Remember, PR is a really sensitive marker of pulmonary hypertension, and you can use your RVOT acceleration time. And again, in the same way as the other measurements we've talked about, there is stronger correlation here compared to systolic pressure, but in terms of there is limits in the limits of agreement. And that is important because remember, when you're looking at direct measurement, you're talking about changes. So if you're looking at a discrepancy of 10 millimeters of mercury, well, if you have a mean PA pressure of 21, but it was actually 31, you've lost your treatable pH, whereas if it was less than 10 and at 11, well, that's completely normal. So it completely changes your diagnosis. So now we are in wedge position. So you can see that the catheter has jumped forward and now holds still. So this is your wedge pressure. And at the point where it holds still, you're at a distal part of the pulmonary artery, and therefore the mechanism of detecting your left side is that you've stopped flow distally. So now what you're sensing is everything from your left side. So it is a surrogate marker for your LV filling pressure, and it transmits your left atrial pressure via the pulmonary veins, via the pulmonary capillaries. And remember, if there's no mitral stenosis, this is a surrogate marker for LV EDP. Now, how do you interpret wedge? So if you've got a wedge pressure of less than or equal to 15, that is considered precapillary. But if it's greater than 15, it's considered postcapillary, and therefore, actually, that is an active left heart problem. And this is what the wedge trace actually looks like. And this is subject to respiratory variation. So you cannot just take the calculated mean from your right heart catheterization data. You really have to look at end expiration. Now, my pointer isn't working, but inspiration is where you go down, and expiration is where you go up, and you take the measurement at end expiration. So for instance here, the wedge pressure is around 910, so this is a precapillary wedge pressure. And for contrast, I'm showing you a post-capillary wedge pressure, where the wedge pressure is clearly higher and higher than 15 here. So this is post-capillary. And now, wedge pressure is where you have your major pitfalls, and so it's really important to get this measurement right. Remember, end expiration, your wedge pressure shouldn't exceed your diastolic PA pressure, and if it is, recheck your zeros, recheck your measurements. You can't analyze this afterwards because you aren't going to be able to go back in, so it's important to get the diagnosis right. And you can confirm the wedge by doing a wedge saturation, which should be close to your systemic saturation. And if it's greater than 90, you know that that's likely a representation of the LA pressure. Your catheter tip really on, when you're doing fluoroscopy, shouldn't be moving. Now, that leads you on to cardiac output, and there are two main methods here. You've got your thermodilution and you've got your FIC, which is direct or indirect. Now, thermodilution is the one that we use as part of guidelines, but there are caveats in low cardiac output states and when there's severe TR, but actually there's still correlation based on research studies. And in terms of indirect FIC, this is related to assumptions, and therefore that is the less preferred option. And putting that all together, so your mean PA pressure, your wedge pressure, divided by your cardiac output gives you pulmonary vascular resistance. And that is actually the resistance that your heart is having to push against. So if you've got a PVR of greater than 2, that is high resistance, and that is precapillary. If you've got a low PVR, pulmonary vascular resistance of less than 2, then that is a passive process, that is postcapillary. And again, the thresholds for PVR have come down from greater than 3 to greater than 2. And the reason for that is that we know that with mild elevations of PVR, there is a worsening related outcome. And that is independent of comorbidity, as we showed in evidence PAH. And you can calculate PVR on your echometrics. You use TRV and RVOT, and there appears to be a correlation. But the cutoffs here were different compared to the new guidelines. And so this is really important. Your ESC guidelines give you normal ranges on the right-hand side here. It gives you normal ranges for the pressures and the calculated values. And your right heart catheterization has got to make sense. So remember, your mean RA pressure should equate to your RV-EDP. Your systolic pressure should be the same as your pulmonary artery systolic pressure. Your diastolic PA pressure should be the same as your wedge, but actually in pH, remember, your diastolic pressure goes up, so should be higher than your wedge, and your wedge relates to your left atrium, so it all makes sense. And this is the hemodynamic criteria for the diagnosis of pH, and therefore we've talked through this. So your pH is diagnosed with a mean pressure of greater than 20, and then you differentiate it into pre- and post-capillary, but you also have this group that is combined pre- and post-capillary, where it doesn't quite fit the mold, where you've got a high PA pressure, a high wedge pressure, but you also have increased resistance. And it's really important to do these tests during your right heart catheterization. The whole thing is trying to determine whether this is PAH or comorbidity. And we tend to do reversibility testing during our right heart catheterizations, look at exercise-induced parameters, and looking at fluid challenge. But it's not just about the hemodynamics. You may get a hemodynamic diagnosis, but you've got to put this back into your clinical classification. And this is where all of your other investigations come in, and where you look at clinical history to look at risk factors. And remember, treatment can only be done at the point where you've got group 1 or group 4 pulmonary arterial hypertension, i.e. where there is vasculopathy. And that's for pulmonary vasodilators. For group 2 and group 3, you treat the underlying cause. And although the treatment guidelines thresholds have come lower with a mean PA pressure of 20, greater than 20, so that's your diagnostic thresholds, your treatment thresholds remain unchanged. So actually you can diagnose PH with a mean PA pressure of greater than 20, but you can't treat it until you have a mean PA pressure of greater than 25, because that's where all of the interventional trials have happened. So let's go back to pathophysiology and endothelial dysfunction. We know in PAH there is a decrease in nitric oxide, there is an increase in endothelin, and there is a decrease in your prostaglandins. And this is where our pH therapy targets lie. So if you look at the nitric oxide pathway, we use PDE5 inhibitors, such as tadalafil, and we use guanylate cyclase stimulators, such as riociguat, and that causes vasodilation. And when you look at your endothelin receptor antagonists, what you use is ambrisentan and macitentan, and that blocks vasoconstriction. And then your prostacyclin pathway, which is the most effective but most intrusive as well, with your IV ipraprostanol or selexipag. We know that that causes vasodilation, but that's, IV ipraprostanol is the only one that also seems to have an anti-proliferative effect. And this is based on multiple studies ongoing from the 1980s all the way through to now. And there is a new kid on the block. And this may be our first DMARD in pulmonary arterial hypertension, and it is sotatercept. And that is a protein-binding ligand, and what you're trying to do is rebalance that signaling pathway abnormality via your BMPR2 pathway. And what you're doing is inhibiting the proliferation pathway through your activins in GDF. And what you're trying to do is repurpose your BMPR signaling pathway to, again, promote anti-proliferation. You're trying to rebalance it. And what you see in phase 3 trials on the right-hand side here is that sotatercept has had major implications in mortality compared to placebo. In fact, the Zenith trial stopped early because it felt ethically unwise to continue when there was such a change in terms of mortality. But remember, sotatercept is not currently funded and is going through NICE approval. So this is the ESC guidance in terms of treatment of pulmonary arterial hypertension. You've got your low intermediate group where you start combination oral therapy with your PDE5 inhibitor and your ERAs. And then you've got high risk where actually you may upfront go with triple therapy with IV epoprostenol. And we know triple therapy is intrusive, but it does, if you start early, it has the best outcomes. And then there is a new arm in terms of treatment, and that's on the right-hand side. So if you've got pulmonary hypertension, PAH, but you've also got comorbidity, you've got to be a lot more careful, and a single agent in the outset is suggested. And the reason for that new addition to the guidelines is because we know in contemporary registries, such as Compara, that patients are now older, they have more comorbidity, so they don't fit this classical phenotype. And when they went to phenotype group 1 PAH, what they found was 3 distinct phenotypes. Your classical one, your young female patients without comorbidity, your left heart phenotype, which patients who are a lot older tend to be female, HFpEF type phenotypes with AF, and you had your group 3 cardiopulmonary phenotype, which are often male patients, low DLCO, smoking history. So how do you determine if it's group 1, PAH with comorbidity, or actual comorbidity in the outset? And that's really important, and that's why we recommend referral to PH centres where you can do provocation testing. And if you do go through giving patients pulmonary vasodilators, they are very closely monitored to assess response. And the reason that is so important in group 2 and group 3 pulmonary hypertension, pulmonary vasodilators come with potential harm. And that is because you still have an increased LV filling pressure, and you can get pulmonary edema and peripheral edema. And you can see in this trial set that there was worse clinical outcomes in the Soviac trial when patients were started on PDE5 inhibitors, and therefore it is a class 3 recommendation that we do not use pulmonary vasodilators in the context of left heart disease PH. Now, to end, to get a diagnosis, you need to understand the underlying pathophysiology, because only once you understand that can you initiate treatment and the right treatment for your individual patients. I'd like to thank BSE again for inviting me to speak, and here are my acknowledgements.
Thank you very much, Dr. Karia. So it's my great pleasure now to introduce Dr. Hebah Nashat to come and talk to us now about the assessment of pulmonary hypertension in those with congenital heart disease. So Dr. Nashat is an experienced cardiologist at Royal Brompton Hospital with an interest in pulmonary hypertension in congenital heart disease, and we really look forward to your talk. Thank you.
Thank you very much. Thank you for the introduction, and thank you for the invitation to present today. So yes, my background is cardiology and with a special interest in congenital heart disease and pulmonary hypertension at the Royal Brompton. So taking a different angle from my colleague, where right heart catheterization tends to be a little bit more challenging, and certainly echocardiographic assessment is as well in these scenarios. So the learning objectives today will be able to find the pulmonary hypertension and the categories in CHD, the application of the BSE probability in this group, and particularly the echo pitfalls that apply in this patient group, and then briefly on the treatment pathways. So we know that congenital heart disease is the commonest anomaly. It affects 1% of live births. It's a cradle to the grave condition. And we also know that with advances in pre-screening and surgery, that greater than 90% of children are now surviving to adulthood. And there is now a greater population of adults with congenital heart disease than there are with children. Very heterogeneous population, very complex anatomy in some patients. And up to 10% of these patients can go on to develop pulmonary hypertension, the broad PH. But it's important that we differentiate, as my colleague did earlier, that there is a differentiation between PH and PAH, where there is a vasculopathy. And in that group, it's much lower, between 1% to 3%. PH has a significant impact on patients' prognosis, exercise tolerance, and quality of life, with reductions in exercise capacity. And therefore, screening and identifying pulmonary hypertension in this group is important, as pulmonary vasodilators have been shown to have an impact and an improvement on prognosis. And as my colleague mentioned, that there has been now a change in the definition. So pulmonary hypertension is an invasive hemodynamic diagnosis. Echocardiography is important in the probability and screening of PH, but it must be diagnosed by hemodynamic assessment. And although the PH, mean PH pressures the hemodynamic definition has changed, it's not entirely reflected in the transthoracic echocardiogram measurements. So the RVSP of greater than 35 still remains as one of the probability markers of pulmonary hypertension. And then it's important then to differentiate that when it comes to the classification of pulmonary hypertension, indeed we have 5 different groups of PH. And commonly, I think anyone who thinks of pulmonary hypertension and congenital heart disease, they're thinking Eisenmenger syndrome or complex congenital heart disease, but it's far more broad than that. So in the group 1 categories, we differentiate these into the Eisenmenger group, those associated with a systemic to pulmonary shunt, those who've had a corrected defect or a small incidental shunt. But it is important that pulmonary hypertension does affect other groups of congenital heart disease, and now emerging is left-sided pathology and LV impairment in the congenital groups, and those with systemic RVs who are impaired. And they present with pulmonary hypertension also, although the management differs. Of course, our patients also have thoracic wall deformities due to surgeries at younger ages, pulmonary artery obstructions, but be it congenital or surgical. And then the really challenging group are the group 5 patients who have a Fontan physiology, whereby you have a passive right-sided circulation and just one pumping ventricle, and the entire system is dependent on a low pulmonary vascular resistance. And so it's important to identify any shifts or increase in pulmonary vascular resistance in that group and treat with pulmonary vasodilators. In segmental PH, only some parts of the lungs are hypertensive, the rest are okay, also another challenging group. A little bit about the National PH Service. So we are, and my colleagues here on the panel are from different areas. We are a national referral service. There are 8 centres in the United Kingdom, and those of us here on the panel are from various centres around the country, a little bit of a cluster in London. And so the National Pulmonary Hypertension Service audits the number of patients that are referred into the service. It was created in 2004 and has been, we submit our data on an annual basis, and there's an annual document of kind of outcomes and adherences to the standards and the guidelines. But what we know is that certainly the numbers are increasing, and the number of patients on active therapies are increasing. And there's always a question mark of where does congenital heart disease fall in this group of patients. And when you compare congenital heart disease group to other groups, we are very much comparable to the group 1 patients alone. So patients with congenital heart disease from the cohorts approximate 34% of the PH service nationally, whereas patients with other forms of IPH make up around 33%. So it's a very important group of patients that are possibly undertreated compared to the other groups of patients. The diagnostic workup of these patients is obviously the basics. We start with our initial evaluations, and echocardiogram and screening forms the fundamental part of our signaling that there may be some evidence of pulmonary hypertension developing in this cohort. Like I said, most of the cradle to the grave condition. A lot of patients with congenital heart disease even remain under lifelong care and require regular follow-up. So screening at every interval and tracking for any changes on the echocardiographic parameters are important if it was to signal that potentially PH is developing. Remember, up to 10% of our patients may develop it, and it will have a big impact on prognosis. The challenge, however, is that does the PH criteria or the BSE data set, does it apply to our congenital patients? And in the complex congenital heart diseases, there are several nuances which we'll go through. And then, importantly, right heart catheterization is fundamental in the diagnosis and managing our therapies. And then also, additionally, we have to measure other things. So comparing the pulmonary flow to when assessing shunts, a QPQS can give us an indication of whether something is going leftward or rightward, and how we can manage that, be it surgical or not. And then there's other special considerations in our patients. So Eisenmenger patients tend to have a high, due to their hypoxia, have secondary erythrocytosis. That will have an impact on the measurements of the pulmonary vascular resistance. So again, there has to be some expert consensus when managing and starting to treat these patients. So the lesions particularly at risk of pulmonary hypertension, so often the pre-tricuspid lesions, so the assumption is that ASDs are a potential contributor to PH. In fact, it's actually far less than the post-tricuspid lesions. So those with ASDs, anomalous pulmonary veins or sinus venosus ASDs, they tend to have a low to moderate risk of developing pulmonary hypertension later in life. And when they do, it often is much later in life. So they may present in the 3rd to 5th decade, or often women after they've had a baby, they may present then with their symptoms. But pulmonary hypertension is, say, in the kind of the lower range of development in this group. Post-tricuspid lesions are certainly at the higher risk of developing pulmonary hypertension. The pathophysiology of that is that you have a lot of excess flow and shunting going from the pulmonary, from the right ventricle through a VSD, directly hitting the friable pulmonary arteries, and shear stress in itself causing remodeling of those vessels and onwards vasoconstriction. And so those with large VSDs, which are non-restrictive, so by non-restrictive means it's wide open, the hole's wide open, big amount of shunting, increases our risk of pulmonary hypertension, and they would present at an earlier stage of life, and those with PDAs or aorta pulmonary windows apply also. The complex congenital heart disease are very high risk, so those with AVSDs or truncus arteriosus, where you've got common circulation hitting both pulmonary arteries and the aorta, and often just by seeing on a transthoracic echocardiogram or other imaging modality that this is present, without any pulmonary stenosis to protect the pulmonary circulation, then you can just go ahead and assume that this patient does have pulmonary hypertension and potentially treat them when you go through with by expert consensus or MDT. The emerging and the growing group of patients, so what we know from the data is that the Eisenmenger population, due to understanding it better and screening, we're treating sooner. The Eisenmenger physiology we're seeing less of. So a lot of them, even in our clinics, we're seeing those who are reaching 50, 60 are now passing away. We're seeing a lot less Eisenmenger patients coming into our service as new patients, obviously because times have changed. And if we do see Eisenmengers, it's often in a migrant population coming into the country. But the emerging populations are those with a residual shunt after surgery or post-repair PAH. Again, there's a lot of not quite understood, but some of the hypotheses is that there is some. A child will present maybe at 3 or 4 years of age. You do the basic hemodynamic assessments. It's not quite significant pulmonary hypertension, and so they won't proceed to having a closure. And then later in life, there is, because of the shear stress that happened in the first, say, 4 to 4 years, they do have some vasculopathy and then go on to develop pulmonary hypertension later in life. And so that is the emerging population. So those who've had a repair are the growing population of patients with congenital heart disease and PAH. So the risk of progression, as I said, with the pre-tricuspid lesions, we said is low to moderate, often will present at 3rd to 5th decade. Post-tricuspid lesions will present earlier childhood or early adulthood. The complex congenital heart disease will be known about since infancy. And then the post-repair lesions will present later in life, and they'll be the patients that you'll be seeing and screening in your echocardiographic laboratories, assessing them later in life. And those, particularly if they've had a post-tricuspid lesion that was repaired at a young age, those who've had transposition of great arteries and had a mustard or Senning repair are also at high risk. So they're the particular patients or those who've had a late closure are the ones to pay careful attention to. So Professor Augustine is going to go through the echocardiographic assessments, but this is the BSE protocol, which we're all familiar with in assessing pulmonary hypertension, and this is a nice schematic diagram from the ESCRS on the different schemes of measuring, of assessing pH in our patients. The majority, they can apply to patients, particularly if the chambers are all in present and there isn't any major shunts. However, a very interesting and very nice paper that was published by colleagues here in the UK, now from 2018, but was almost a statement piece in JACC on the echocardiographic screening of patients with pulmonary hypertension in congenital heart disease. And this particular group, they carried out a survey of physicians in the United Kingdom of what is the important echocardiographic parameters to measure when there is pH. A systematic review was done, and then consensus expert recommendations were formulated. And so in this particular slide, we won't go through it all, but it tells you here that, you know, we have to be lesion specific when we are measuring the different standard echo parameters. So where they, for example, in a patient, if they have say a pulmonary stenosis or an RVOT obstruction, then we know that the RVOT or the TR gradient is not reflective of what the true pulmonary pressures are, and so therefore the standards do not apply if your patient presents is being scanned with pulmonary atresia, pulmonary stenosis, or double-chambered RV. Furthermore, when we have patients who've got univentricular hearts, the standards again do not apply when we're measuring the diameters of the or the volumes of the right ventricle and the left ventricle. And then in patients who've got severe tricuspid stenosis or regurg, or again restrictive physiology, particularly in the context of patients with tetralogy of Fallot, the diameters of the vena cava will be different, and there again we'd have to may not the same standards and the validated tools that are used in other hearts will not apply in these particular patients. The other thing that they did in that paper was they did a systematic review of many papers, and they again it was the conclusion was that we don't have validated echocardiographic parameters, and all these different CHD lesion specifics in all these CHD lesions are not entirely validated, and therefore the echocardiographic assumptions are based on understanding what the anatomy is, importantly that we screen for pulmonary hypertension at every stage, but how do we, what will alert us is if there's a change. So it's really important that we're tracking that, you know, if there's changes in the right ventricular sizes, dilatation, elevations in pulmonary pressures, or other parameters that are showing that there are progress or changes that are important in this particular group. And then we're going to go through then some of the, with regards then to which echocardiographic parameters do apply in these particular groups. Well, many of them may not always support it, as we've said, and there's, like I said, a good need for the understanding of the anatomy, and that overall there are further studies that are needed to understand what the recommended cutoffs are in this particular patient population. Looking then specifically at some cutoffs, some lesions. So when we're looking at patients with an RVOT obstructions or pulmonary stenosis, depending on the severity of stenosis, there may be a mild to severe pressure gradient. But it is important that that the use of the pulmonary that we have to use the pulmonary regurg Doppler in estimating sometimes the PA pressures. But at the end of the day, it is down to kind of consensus review of the anatomy and then invasive hemodynamics going beyond a stenosis on whether this patient has pulmonary hypertension. In the unrepaired or the palliated complex pulmonary atresia patients, the identification of patients who may have segmental pulmonary hypertension is by echocardiographic analysis is extremely difficult. You would have to have, it does require clinical suspicion, and sometimes the Doppler gradients of the collateral vessels may indicate that there is some underlying pulmonary hypertension there. Large PA or collateral dilatation is also another, may also give us an increase of suspicion that there is evidence of pulmonary hypertension that's developing in this particular group, particularly in those who don't have, particularly if they don't have protected pulmonary circulation, either by banding or PS. And then in the univentricular circulation, both the PA and the aorta are exposed to systemic pressures. If there isn't any pulmonary stenosis or subpulmonary stenosis, then we can assume that there is underlying pulmonary hypertension, and that the echocardiographic estimates of the PR gradients are also helpful then when screening these particular patients in those with unrepaired univentricular hearts. This particular group is high risk. We don't know why, but they are a high risk for developing pulmonary hypertension despite timely repair. And then later in life, these particular patients, because they rely on a systemic right ventricle, also develop some forms of post-capillary pulmonary hypertension, so a failing systemic right ventricle. And so they may be hit by either two ways, by a precapillary component or a post-capillary component to pulmonary hypertension. And again, the index of suspicion is raised if there is changes in mitral regurg gradient. So in these particular patients who ultimately had a transposition of the great arteries, the left ventricle is now your subpulmonary. And so it's a left AV valve regurgitation is where you would assess your parameters for pulmonary hypertension rather than the what's seen on the right. And so also importantly, if there's any changes in the sizes of the pulmonary arteries or changes in the size of the chambers, may also indicate that there is a development of underlying pulmonary hypertension. But overall, we would confirm all this with cardiac catheterization. Briefly then on treatments for these patients. So my colleague's already gone through the treatment pathways. Yes, they apply to congenital heart disease. However, the risk stratification tools and assessments that we use for other forms of other hearts, normal hearts, are not validated in patients with some forms of congenital heart disease. Often it was the post-repair patients that would be used as when validating these markers, or even in the clinical trials. But when it comes to patients with left to right shunts, Eisenmengers, they're often excluded, and so our risk assessment protocols don't always apply to this group. Furthermore, in patients with Eisenmengers, they often have a very well recruited right ventricle, which is only hypertrophied and functions very well until later in life, and it's when the RV starts to fail in an Eisenmenger, you know that the pulmonary hypertension is end stage, but they can be pulmonary hypertensive all their life with a very good right ventricular function. We do start with monotherapy, and it's a systematic escalation in therapies according to changes in their symptoms, and sometimes echocardiographic changes, but often we would look at parameters like their functional class, walk distances, and BNPs to decide on whether we would escalate therapies, which is the standard. The newer therapies coming through the sotatercept or the activin signaling pathways, unfortunately in patients with shunts or Eisenmengers or our complex patients, they have very high secondary erythrocytosis. And one of the side effects of this new wonder drug, which we're really looking forward to seeing, is sotatercept, is cannot be used in this particular group because it can elevate their hemoglobins even more. So it's not likely to be a medication for our patients still, again, like most of the things. But we are relying on the pulmonary vasodilators, where there is evidence to suggest that, yes, endothelin receptor antagonists and phosphodiesterase pathways work, prostanoids less so. And heart and lung transplantation is the potential ultimate, but then that's also a golden nugget. The novel echocardiographic parameters that are coming out, do they apply to pulmonary hypertension in congenital heart disease? So the RV, we'll hear a little bit more about the RV-PA coupling later. It is a valuable, simple tool which can complement our traditional functional assessments. Again, requires careful interpretation and lesion-specific, particularly if there's a shunt. Will that affect the numbers? Can we always use it? But it requires further validation with congenital lesion-specific detail. And then 3D echo would be the right ventricle in congenital heart disease comes in varying forms, again, depending on the lesion. So 3D echo could potentially be transformative in evaluating the RV in congenital PH patients, and could be used potentially as a prognostic value in addition with other imaging marker and other biomarkers in making diagnosis and following up patients. And then RV strain is which we know in other scenarios is a very powerful, sensitive, and prognostically relevant tool, and work what will hopefully emerge more in our lesion-specific congenital patients. We need to find other ways and validate these new novel parameters in these particular patients in the future. Because overall early detection and treatment in this particular group is really important, and we know that there's a large proportion of patients coming. The congenital population in the UK is growing quite rapidly. So overall, then, my take-home message is that congenital heart disease is one of the major drivers for pulmonary hypertension, reflected both as it affects 10% of the population, and in our national audit, we know that approximately a third of the patients in our centres have congenital heart disease. Early detection is crucial, and that echocardiography is central to the diagnosis, risk stratification, and serial monitoring of these patients. But it's very important that there's nuances when we are scanning these patients with CHD, and there should be potentially the development of lesion-specific protocols for certain types of anatomies, and that parameters that are validated with other forms may not be applicable to our patient groups, particularly in those with complex anatomies, and that targeted therapies are still the mainstay of treatment to improve outcomes, and overall it's always going to be down to multidisciplinary and expert consensus in managing these patients. Thank you very much.
Thank you very much, Dr. Nashat, for this excellent overview on a very complex topic. And now it is my great pleasure to introduce Professor Abdul Hameed from Sheffield Teaching Hospitals. He is a consultant cardiologist and an expert in pulmonary hypertension.
Oh, hi, good morning. So thanks to the BSE for inviting us to talk. And it's been really nice this is my first attendance at the BSE. I really liked the atmosphere and the evening yesterday. Everybody was really friendly. So it's been great. And also, I used to study down here, down south in Southampton and Bournemouth, so it's been really good to come back. So I'm just going to cover pulmonary hypertension associated with left heart disease. I have no conflicts of interest, just interest in this field. And the objectives are to outline, the mechanism, the clinical impact and prognostic implications of pulmonary hypertension in left heart disease, to go through how we use echocardiography and other parameters to assess left heart disease, and just cover some other future aspects of stress echocardiography, and also we'll touch upon treatment. I'm going to use more practical and case-based examples to illustrate this field, because this is the commonest form of PH that you'll see. Now, I appreciate it's Saturday morning after a Friday night, so I've decided to give you the take-home messages up front. Over 50% of pulmonary hypertension is caused by left heart disease or associated with. And here you see this schematic on the top right. Essentially, the red side of the circulation from the pulmonary veins onwards, involving the mitral valve, the left ventricle, aortic valve, the aorta. Pathology in one or more sites basically classifies or categorizes left heart disease. The other thing is, when we assess LV diastolic dysfunction and filling pressures in the context of HFpEF, heart failure with preserved ejection fraction, it can be much more challenging compared to things like valvular heart disease or LV with reduced ejection fraction. And we shouldn't, as clinicians and also as physiologists, we shouldn't really be just utilizing one test, because nothing is absolute and nothing always fits. We have to put things together. So the part of the jigsaw involves clinical features, imaging features, and it's not just about echocardiography. You've got to use other tools, physiological tests, lung function, etc., cardiopulmonary exercise tests, and right heart catheterization. So we put all that together to formulate a diagnosis. When we're doing a plea to my colleagues who are physiologists and reporting echocardiograms, including clinicians, when expressing the probability of pulmonary hypertension, I would also advocate that you should summarize, at least in the conclusion, the extent of left heart disease, because although it's been useful to have probability of PH, when it comes back to the person who reads the report, if it just says high probability of PH, they will basically then turf off the referral to somebody else. And we have a lot of those referrals. And I think helping people to understand what some of the factors that may be there would be helpful. In patients with significant left heart disease, but also significant right ventricular dysfunction and pulmonary hypertension, you should consider a specialist opinion. Now, my colleague has summarized the 5 groups of PH. Group 2, in the middle, on the top left there, is very common, up to 50%. Group 3, lung disease, is also very common. Between them, they account for 75% of cases of PH. So the pretest probability of somebody coming for an echocardiogram for whatever indication, having pulmonary hypertension, is very high that they will have left heart disease. The other thing to say is that patients can have more than one group because of our older generation, multiple comorbidities, etc. They often have left heart disease and lung disease. They could have chronic PE as well. They may have liver disease, etc. Now, within the group 2 left heart, we've got the heart failure with reduced or heart failure or LV dysfunction with varying degrees of ejection fraction, okay, as well as valvular heart disease. Fundamentally, there is a spectrum. It's not completely linear. Some patients will have a left heart phenotype. Other patients will evolve and have a right heart phenotype, but there's RV dysfunction. It involves elevation in LA pressure, depending on the severity and the duration of the left heart disease. For example, the archetypal condition back in the days was severe mitral stenosis. You didn't get a surgery, or unrepaired congenital heart disease, or with left heart problems, they will develop severe pulmonary vascular remodeling. Some patients may have other contributors that will give rise to the right ventricular phenotype. When I say that, I mean the right ventricle's hypertrophied, it's dilated, it's impaired, but there's also left heart pathology as well. And across the spectrum, we believe there is this right ventricular pulmonary artery uncoupling. In addition, though, we also have high flow states. You don't have to have a primary left heart problem, but other pathologies can modulate the left heart structure. For example, shunts, liver disease. Often ASDs will present later in life because the left atrial compliance is reduced and you get increased the flow, but they will still have left heart disease. A lot of our liver patients will have increased cardiac output, thyroid disease, anemia, etc. And as I said, left heart disease often coexists with other PH groups. Now, what's the frequency of PH and valvular heart disease? So this is an invasive study using cardiac catheterization in aortic stenosis. So there's about 4,000 patients here that they've done cath on. 30% of aortic valve disease will have pulmonary hypertension some degree. 50% to 60% of mitral valve disease will have pulmonary hypertension. In terms of the severity, so most of it is mild or moderate. Severe in 5% of aortic valve disease, 10% almost in severe mitral disease. Now, mitral regurgitation is a common lesion, and severe aortic stenosis is a much more common lesion, and you will be increasingly encountering this in those who undertake structural programs. This is a large inpatient study from America, just looking at the diagnosis in 6 million cases of left heart disease. These are hospitalizations, and pulmonary hypertension was present in about 19%, and it varies depending on the type of underlying left heart disease, but you will see at the bottom that mitral stenosis is the worst, end-stage heart failure, mitral regurgitation. These are just diagnostic codes. They may have used different ways of diagnosing it. Some are echocardiographic based, some are invasive. That's not clear, but it's just to illustrate that pulmonary hypertension is common. For those of you doing inpatient echocardiograms in a patient presenting with heart failure and they request one, invariably, if the patient's got peripheral edema, they will have pulmonary hypertension with their left heart disease. Now, we know from this is national UK data that these are referrals to a pulmonary hypertension center, so obviously there is some referral bias. Left heart disease in grey, the number 2, has got a median survival 50% of about 4 to 5 years. So it's not a benign condition, and it obviously encompasses all types of PH left heart disease. These are fundamentally hemodynamically diagnosed as well. Most of them will be HFpEF. We often get referrals from cardiac centers where they say there's no mitral regurgitation, the LV function's okay, so therefore they don't have left heart disease. And I think that's misleading because they've not fully looked into the other finer details. So what are the requisites for PH and left heart disease? Well, clearly you have to have some evidence of pulmonary hypertension, either an imaging or invasive assessment. They have to have some spectrum of structural left heart disease, either affecting the valves, the ventricle, the left atrium, or all. And they will have elevated LV filling pressures, either at rest or with exertion. And if they've got what we call latent or occult increased filling pressures, then you may be able to induce that with a diastolic stress test. You can use exercise stress echocardiography. We can do passive straight leg raise and increase their LA pressure, or we give a fluid challenge during right heart catheterization to unmask that, or we can do an exercise right heart catheter and invasive CPET. We don't do invasive CPETs in our service, but we do exercise right heart catheterization and all the others. So when you're diagnosing pulmonary hypertension with left heart disease, we've got three components. You've got a clinical probability, a pretest probability, you have imaging, non-invasive assessment, and then you've got an invasive assessment to characterize that. I'm going to go to the invasive side because obviously pulmonary hypertension is a hemodynamic diagnosis and therefore involves numbers. But most of the time we don't necessarily need to use invasive measurements depending on what the context is and what the plan is, if it's, for example, valvular heart disease. So here, I know, so pH, we've already been through, is high, elevated mean PA pressure, depending on the wedge pressure. If it's more than 15, we say this is elevated wedge pressure. If it's less than 15, it's precapillary. The normal range for the wedge pressure actually is being debated, and actually it should really be less than 12. Anything between 12 and 15 is borderline, and 12 and 18 is the gray zone. And you've got to remember that when you assess this, it depends on the loading conditions and the fluid status of the patient. So a patient that's been well diuresed may have a normal wedge pressure, but they've got structural left heart pathology. So you cannot ignore the fact that just because the wedge is normal doesn't mean they don't have left heart disease. It could be that you've treated the elevated filling pressures. And I've got some cases to illustrate that. We talked about partitioning depending on the PVR. A PVR of more than 5 Wood units is classified as severe combined post and precapillary pH. And those patients have a much more worse prognosis compared to others. So I just wanted to talk to you about what is elevated wedge pressure. What is it conceptually? So normally in you and I, our wedge pressure here in number 2, it may be between 5 and 8. The pulmonary artery pressure should be less than 20. So it's, let's just say it's 15. There's always a small slope from the lung to the left heart. It's just nature. And that's how bulk flow allows blood to move through a pressure gradient. In precapillary pH, you've got a very big steep hill where the problem lies on the blue side of the circulation. There's a vasculopathy, as my colleague alluded to. But in left heart disease, this is a simple analogy that I like to use, and I hope it resonates with you guys. The hill is, top of the hill is the lungs, and the lake at the bottom is the left atrium, the left heart. So when the pressure within the lake fills up and increases either with rest or exertion or with heart failure presentation or decompensation, the pressure has to increase in the pulmonary circulation to maintain the runoff down the hill. So that's how you should think of left heart disease. And that is a dynamic process. So if you've got isolated post-capillary pH, your wedge pressure goes up, but your PA pressure, mean PA pressure proportionally goes up to maintain that same gradient. It almost looks like the normal slope that we see in normal individuals. But in some patients, they can get a disproportionate rise in the pulmonary artery pressure. And that's either because the pathology in the left heart is of sufficient severity and duration to induce that, so for example, severe mitral valve disease, or there may be other components, and this is where we have to try to tease out what that is and what's treatable. They may have lung disease, they may have chronic PE, they may have group 1 risk factors as well, or etc. So coming back to this, in terms of the clinical pretest probability, we use certain factors. The older you are, how many risk factors you've got, obesity, hypertension, the more of those you accrue, you're more likely to have left heart disease. Is there known left heart disease, for example, more than moderate mitral regurgitation, aortic valve disease? Has there been previous pacemaker ablation for AF? Okay, previous bypass surgery, etc. What's the duration and type of atrial fibrillation? So the more of them you have, the more likely you're going to have a pretest probability of left heart disease. This is important for us when we do cardiac catheterization and evaluate these patients. And then coming back to the imaging, which is the focus of this talk, but I wanted to give you the wider perspective of how to assess these patients. You have a right ventricular assessment or a right heart, so we look at the things that we've already talked about, right ventricular size, the presence of hypertrophy, the Doppler gradients. You all know about the pitfalls of TR Doppler and how to get that signal, or where there's an incomplete signal, and then other metrics of right ventricular function. And you can use TAPSE PASP ratio. In our experience, TAPSE in right ventricular pressure overload is often the last thing to become abnormal, so you can have reasonable, that absolute TAPSE value may be within normal, but they can have severe radial dysfunction. And then you've got a left heart component where you look at the left ventricle, the left atrium, the presence and severity of any valve disease, looking at the Doppler profile to determine the type of filling, okay, whether it's normal filling pressures or elevated filling pressures. And then you know, this is the kind of how you break that down. So this is just an echocardiogram where you've got right ventricular dilatation, right ventricular hypertrophy, and a D-shaped systolic septal flattening with eccentric LV with a high TR velocity. So this is what we would call a precapillary echocardiogram. But this can be encountered in group 1 PH. People with severe lung disease can have this. People with chronic PE can have this. Group 5 can have this. Okay, some people with left heart disease, obviously there'll be left heart factors, could have this type of right ventricle as well. So this is what we call a precapillary echocardiogram phenotype. Doesn't necessarily tell you what the etiology is. There may be clues, there may be congenital heart disease, for example. And so this is a nice infographic from Benita Anderson that summarizes when you've got precapillary PH, the intraatrial septum is bowing towards the LA. There may be right ventricular dilatation and hypertrophy. You should have normal TDI Doppler indices of the mitral valve. There will be mid-systolic notching of the pulmonary artery waveform, which reflects wave reflection and increased PVR. In contrast, the opposite end of the spectrum is your archetypal patient with a massive left atrium of 150 mils, presence of atrial fibrillation, predominantly circular left ventricle as opposed to a D-shaped left ventricle. They may often have diastolic septal flattening because they have severe functional tricuspid regurgitation. The TR can vary between, mild, moderate, severe, torrential, and obviously we know about the guidelines from the BSE are available on pulmonary hypertension, the right heart, and right-sided valves. The Doppler indices can vary. The IVC will be dilated or may be dilated, and the TR velocities can range between 2.8 all the way up to 3.5 or higher, depending on what. So this is the other end of the spectrum, where you have left heart disease. And the postcapillary PH echo clues are elevated TDI velocities. The intraatrial septum, if you look at the intraatrial septum, which way is it bowing? Is it bowing into the RA? That would indicate that LA pressure is higher than RA pressure. You can look at the absence of notching. There is a ratio where you can compare the TR velocity divided by the E over E prime to give you an indication. There have been various echocardiographic scores that have been used to work out is this precapillary or postcapillary. There's nothing that's absolutely hard and fast in life and also in medicine. So we obviously weigh things up. Now, the BSE guidelines last year on LV filling pressures and diastolic dysfunction have created these really helpful algorithms to work out LV diastolic, the presence of diastolic dysfunction, and to determine whether the filling pressures are raised at rest or not. And there is an algorithm for obviously each component of normal LV systolic function, impaired ventricular function. And when AF is present, there's an algorithm. But fundamentally, you're using, TR velocity, provided there is no other reason for high TR velocity. But often left heart patients will have COPD and lung disease, so they may have another reason for increased TR velocity. There are other supplementary indices as well. Within the guidelines, there is a study based in 100 patients that looked at in post and precapillary PH, and they suggested this algorithm about 15% of those patients had atrial fibrillation. So obviously you can't use EA ratio in that situation, and therefore they recommended the use of LA reservoir strain cutoff of 16% to detect or suggest elevated LV filling pressures. So as I said to you, one of the requisites for if the filling pressures are normal, you could do a stress test, and that could involve exercise stress echocardiography as well as invasive forms of diastolic stress test. Now, HFpEF is a very heterogeneous group of patients. You know, we had talks yesterday on amyloidosis, restrictive cardiomyopathies can do this, and there's lots of things that can mimic this phenotype, but there is a HFpEF type of score. There's a European score and an American score looking at certain factors, and you will notice that actually many of those components are what are proposed in the diastolic criteria. And the exercise right heart catheter can look for an elevation in the wedge pressure or the slope of the wedge pressure to cardiac output, as well as resting numbers. So if your resting wedge, as I said, is over 15, or we can give a fluid challenge and your wedge pressure rises to 18, it would suggest that there is latent LV diastolic dysfunction. We can use exercise stress echocardiography. So this is in 2,000 patients looking across the board from athletes right through to patients to look at the relationship with the change in your pulmonary pressure from rest to exercise divided by the flow, the cardiac output at rest and exercise. So that delta change, using echocardiography, a slope of more than 3.5 indicates an abnormal response to the pulmonary vasculature. Now, those of you who are green athletes who went for their morning 6 a.m. jog or bike or swim would have increased their cardiac output from 5 to 10, 15 liters. Dan Augustine, when he signed into the gym at 6 a.m., would have been doing this. But his pulmonary artery pressure does increase a little bit, but the relationship and the ratio is normal. If you go to healthy controls, people in orange who are cardiovascular risk factors, they will have a blunted response, but it stays below the cutoff. They looked at people who lived at high altitude at 4,000 meters in Bolivia. The hemoglobin was like 180. And then you've got people with systemic sclerosis who don't have pulmonary hypertension. And then you've got lung disease, left heart disease, and pulmonary arterial hypertension. So they have a very exaggerated response. Their pressures increase within the pulmonary circulation, but they're not able to maintain the same cardiac output, so therefore the ratio increases. There's another really nice study looking at pulmonary vascular disease and pulmonary hypertension across the different types. The reference is there. You have reductions in peak VO2, the delta change in cardiac output. They're unable to increase their cardiac output for the workload. So the guys in red with the combined post and precapillary pH, they have the least reserve, and so they have RVP coupling. They looked at LA reservoir strain, hemodynamics. So this was a CPET, echocardiogram, and a right heart catheter simultaneously performed. It's a very nice pathophysiological study. So I've got a case to illustrate and wrap up. This is a 60-year-old patient with cirrhosis or liver disease that they were considering for transplant, and they did a local right heart catheter. The letter referral only mentioned the mean PA pressure of 50, and they said, well, obviously because the poor patient's got pulmonary hypertension, we're not able to do a liver transplant or consider them for that at this moment. This is the echocardiogram, so they referred them to us, and this is just to illustrate how we look at all of these things. So we can see that the left ventricle has good function, the left atrium looks big. These are the metrics. The LA is severely dilated, the LAVI volume index is 66, the E over E prime was 17. Okay, there's no mitral annular calcification. There was mild MR, mild septal flattening. But if you look at the AVV max was 2.4 meters per second with a widely patent aortic valve and no aortic regurgitation. So there's a high transvalvular flow velocity. The RV is mildly dilated but with good function. There's a high TR velocity of 4.5 meters per second, so obviously there's a high probability of PH. The TAPS is good, the S-wave is good. There's a trace of a pericardial fusion. So those indicate to you that there is pulmonary hypertension, but there's also elevated LV filling pressures, high transvalvular velocities. So this is just the LVEF, obviously confirming 72%. The LV end diastolic volume is increased. The stroke volume, you will notice, is 116 ml, so there's a high stroke volume here, okay? LV strain is normal. RV free wall strain was also normal, so indicating there's good RV function. So it's coping quite well with a lot of blood going around. LA strain is slightly reduced, not entirely normal, but doesn't meet the cut-off criteria that's been proposed. LA reservoir strain of 24%. I'll let the strain experts comment on the quality of the tracing there. This is the right heart catheterization. So the RA pressure is 17, so elevated. The mean PA pressure is 52, so 90/29. High pulmonary pressure. The pulmonary wedge pressure is 28, but there's a big V wave. The V waves are these spikes here. They're like the little, it's like a capital A. And these just are a sign of non-compliant left atrium. It can be a stiff left atrium or non-compliant left atrium. It can signify severe mitral valve disease. It depends on the context. When we see that, that's a very strong clue that there's left heart disease. But the cardiac output is nearly 9 liters with a cardiac index of 4.75. As a consequence, so there is high pulmonary pressures, but there's also high flow. The PVR is only modestly increased. Yes, it is increased at 2.75 Wood units. The saturation in the SVC is 69 and the pulmonary artery is 72. There's no intracardiac shunt. We took a wedge sat, which is 98%, confirming that that wedge pressure tracing is not an erroneous measurement. So this patient had severe pulmonary hypertension, but had high output and combined. So I just used to say how we can illustrate and assess using non-invasive as well as invasive assessments. So this patient, normally we didn't treat with pulmonary vasodilators because they've got very high wedge pressure. And often it's because of the liver disease. And so because of the high output state, it's unmasked the left atrial hypertension. So this is just the take home that I mentioned earlier on at the start, just to summarize up there. Thank you very much.
Thank you so much, Dr. Hameed, for that very interesting talk. So in the interest of time, we're going to move on, and we're very pleased to welcome Dan Augustine to the stage. Dan needs no introduction. We're really excited to hear you speak, Dan, about the BSE guidelines. Thank you.
Thank you. Morning, everyone. So, so I'm going to give you some perspectives on the upcoming BSE guidelines that will be published next year. And the reason I think perspectives are important rather than going through the algorithm is that, and you'll know from European-based practice, we look at a probability-based approach. The American guidelines, which were published in July, have gone back to estimating PASP, and based on what the PASP is and saying whether there's mild, moderate, or severe PH, but actually understanding the important perspectives is what's going to help us to finalise an echo report that's clinically relevant, I think, rather than just having a rigid algorithmic approach, whether that's European or American. We've seen this slide. PH has 4 categorizations. The most common cause that we'll see in our echo departments by far is due to left heart disease. Very sadly, it can be 2 to 4 years from symptom onset to the actual final definitive diagnosis of PH, and that's important because untreated, some of these forms of PH can be reversed with appropriate therapy, as we've heard from before. So the first perspective that we want to get across in the guidelines next year is that it's really important for us to think about the clinical phenotype before putting the probe on the patient, to clinically phenotype the patient, look at the information we have from a clinical perspective, because that will inform us as to how accurate the output from the report is. So for precapillary pH, we know that, say, IPAH group 1s, it's less readily diagnosed in the more elderly population. It's unusual to diagnose IPAH in your 50s, 60s, 70s. Think about risk factors for precapillary pulmonary hypertension, connective tissue disease, lung disease. Do they have risk factors for CTEPH? And then Abdul's really nicely gone through post-capillary pH, and so what we want to drum home are our risk factors for post-capillary pH. The age, are we looking at a more elderly population? Is there hypertension? Is there elevated BMI? Is there diabetes? Is there AF? Think about left-sided valve disease and reduced ejection fraction. So actually, before doing the echo, have a clinical, systematic approach in terms of phenotyping the patient. And that's important because we've seen that the actual hemodynamic classification of pulmonary hypertension has fallen. And so actually some of the echo markers that we used on a daily basis, TAPSE, other RV markers, tissue Doppler, pulmonary artery systolic pressure, TRV, in those with milder hemodynamic forms of PH, who have PH, these measures are probably going to be normal. And so that's why we need to have a think about a systematic approach, a multi-parametric approach to the assessment of these patients. We need to understand the limitations of pulmonary artery systolic pressure. We use TRV, we put it in a Bernoulli equation, we add an estimate of right atrial pressure, and if there's no obstruction to the outflow tract, then that should be equivalent to our pulmonary artery systolic pressure. But there are inaccuracies in the way that we use TRV to estimate pulmonary artery systolic pressure. We know that if you have eccentric jets, then it's hard to align your Doppler accurately. We've all had cases like this where there's poor signal. Where is the actual peak TRV? TRV naturally will increase with increasing BMI and increasing age. And we've all had cases of severe free flow TR where that right atrial pressure is very high and it's chronically been elevated. So the flow, the pressure difference between the right ventricle and the right atrium is less, and the TRV will be less. So if we put that TRV into the Bernoulli equation, we're starting with an error, we're squaring that error, we're then quadrupling that error. So you can start with a small error at baseline and magnify. And that's why I don't think we can wholly rely on PASP to say this patient has pulmonary hypertension or not. And the other thing which was touched on really nicely is that the reason PASP, another important reason why PASP is inaccurate is the right atrial pressure assessment. We do our best with inferior vena cava size and collapsibility, but it's just not accurate when you compare it to right heart catheter measurements, and a lot of the error that we're making in PASP comes from this. And there are lots of papers that show this. This is just one example where they've compared it with the right heart catheter and the accuracy was 34%. Lots of population data that shows, unfortunately, echo PASP isn't as accurate as we would like when we compare it with right heart catheter. The correlation on the left graph with the red box is good. You can see the correlation is pretty good. But when you look at the right plot, the bland Altman analysis shows that there's wide limits of agreement. So in our department, we've shown that there can be discrepancies of 20 to 30 millimeter mercury between echo PASP and right heart catheter PASP. The other thing to say is that if we don't have a TR jet and we don't have a TR measurable and no TRV, then that definitely doesn't mean that there's no pH present. This has been shown in nice American data, this registry data, where they've looked at patients having right heart catheter and echo within 2 days of each other. They then looked at those who had no TRV, and about 17% of that initial 1,200 patients had right heart catheter pulmonary hypertension, and the mean pulmonary artery pressure they were using there was, before the change in 2022, 25 millimeter mercury. So the second perspective from the guideline that we want to get across is to understand the limitations of PASP accuracy. The higher the PASP, the higher the likelihood of pH. That sounds silly to say, but I think that holds true with the current TRV that we're using. So we're currently using a TRV of 3.4 for that high probability approach, and that would equate to, with normal right atrial pressures, that would equate to something like a PASP of 50 to 55. So I think we're quite comfortable saying, you know, if you've got a high TRV out there, or a higher PASP above 50, then you probably have got pulmonary hypertension. But below that, we need to think about clinically what is the pretest probability of the patient having pulmonary hypertension. And pulmonary hypertension can definitely be present if you've got a normal PASP and no TRV or a low TRV. And so the clinical context is really important. If you have a breathless patient with scleroderma and the PASP is normal and the TRV is normal, we still need to chase a diagnosis of whether there's pulmonary hypertension being present. And as I've said, just bear in mind about the inaccuracy of right atrial pressure. Third perspective is that whichever guideline you use, whether you're in America or in Europe, there has to be a multi-parametric approach to the assessment of pulmonary hypertension. These are the recent American guidelines, and you can see there different clinical and echocardiographic parameters in the red box. At the bottom left of this schematic, you can see that ultimately they are grouping patients into severity classifications based on that pulmonary artery systolic pressure. And as you know, in Europe, we use a probability-based approach. On this table, I've tried to summarize globally what's in the American guidelines and what's in the European guidelines in terms of the other echo markers that we use, grouped into three categories: the ventricles, the pulmonary artery, and the inferior vena cava, right atrium, and the hepatic veins. This is what we use in Europe, in the UK and around Europe, is a probability-based approach where we start with a TRV, We then see whether there are other echo markers present, and depending on whether there are echo markers in at least 2 of those 3 categories, we assign a probability as being either low, intermediate, or high probability of pH being present. The fourth perspective to get across is that actually most patients who have right heart catheter pH will have some echo markers. It's unusual to have pulmonary hypertension without echo markers, and we've got some data that's about to be published from UK centres that shows in our experience, those who have a TRV of over 2.8, most of them will have other echo markers in order to have pulmonary hypertension. Only about 5 or 10% of those with a TRV greater than 2.8 did not have any other echo markers. So take-home message here is that if you have a TRV of greater than 2.8, you would usually have other echo markers to support a diagnosis of pulmonary hypertension. But there is room for improvement. There's room for improvement whichever guideline you use. This is data from our lab where we looked at the sensitivity and specificity of current guidelines. We showed that that was 89% and 68% respectively. If we looked at those who had a high probability of pH, about 96% of them had right heart catheter pH. If you had an intermediate probability of pH, about 76% of them had right heart catheter pH. But what was striking is that if you had a low echo probability of pH, about 1/3 of them had right heart catheter pH, and they had hemodynamically less significant pulmonary hypertension. So you can see on the top curve in the green bar, their mean pulmonary artery pressure was 23, 24 millimeter mercury. So there is a group of people who do have pH, but our echo markers aren't sensitive enough. And so what we need to strive to develop are other echo markers which are sensitive to detect milder hemodynamic forms of pH. In that low probability group that I just described, the only echo measure that we were able to show that could distinguish pH from no pH was right ventricular free wall strain. So RV free wall strain has been mentioned in the ASC guidelines, and it will be mentioned in our guidelines, which will be published next year. Chris Wild, one of our research physiologists in Bath, presented this data at the ESC last year. And so all we did is we added right ventricular free wall strain into the current echo probabilities. And what we showed that it improved the sensitivity to 92%. There wasn't much change in the specificity. But importantly, it reduced the false negatives by almost 50%. And almost all of them were in that low echo probability group. The next perspective is, when we're thinking about our echo report, is to think about, when you're doing the report, about what the phenotype is from an echo perspective. And so, markers of precapillary pulmonary hypertension, if you have a pulmonary acceleration time of less than 80 milliseconds, abnormal is less than 105, but there's good data to show that if it's less than 80, it's more likely to be precapillary pH. Think about your pulmonary systolic notch. You're more likely to get that in precapillary pH. And Abdul's gone through, I'm not going to go through left heart disease. Abdul's done a great job there. What I would say is that there's a grey zone. There's definitely a grey zone for E by E prime. So if you've got an E by E prime of 9 to 14, please don't discount there being elevated filling pressures on the left side. And these patients, actually, if you're still thinking, is there diastolic dysfunction, they've got intermediate filling pressures, these are the ones we should be putting on the bike and exercise testing. The last perspective that we will come to in our guidelines is signposting for the need for echo surveillance, or the need not to keep people on echo surveillance. So we'll be signposting. So if you have raised right heart pressures and pulmonary hypertension due to valve disease, how frequently they should be followed up. Likewise with left heart disease and respiratory disease, it's actually just treating the underlying cause, and many of these patients don't need further follow-up. This is my last slide. So there are a number of strengths for echo. Echo will continue to be the leading imaging modality for the assessment of pH. It's the best imaging modality, I think, for the assessment of diastolic function. We've talked about limitations, reduced sensitivity in milder forms of pH, inaccuracies with some of the Doppler measures. We need more real-world data to help improve echo criteria. I think the future is an imaging clinical risk-based algorithm. Strain's going to be an important part. AI won't feature massively in the next guidance, that won't surprise you, but it will be probably in future iterations. Thank you.
Thank you very much. Wonderful presentation. And now we have two clinical case presentations. The next is Dr. Zafar, who will present significant improvements in right heart function in a patient with precapillary pulmonary hypertension and advanced renal and lung disease.
Thank you, BSE, for giving me this opportunity to be here today. Just going to a couple of cases, really, my colleague, but this is a very interesting case in a patient with a severe PH and an underlying severe lung and as well as renal disease. I don't have any disclosures other than that. I've only got 5 minutes to go through this case, so please bear with me. Understandably, you've already seen the slide in the last few talks, but just to set the scene and just to quickly go through the definition of pH, which is basically defined as having a mean pulmonary artery pressure of more than 20 millimeter of mercury. And we know that the pulmonary arterial hypertension, pH, is basically classified into 5 different groups, starting from the pulmonary arterial hypertension, then pH caused by the left heart disease, lung disease, coronary thromboembolic phenomenon, and understandably the most complex, which I seem to think is a very complex one, is a heterogeneous systemic condition, such as patients with hematological conditions, as well as patients with renal failures, which we often see quite frequently in our clinics. I know Dan was talking about the probability assessment of pH, and understandably there are some other parameters which are being developed, including RV strains and LA strains, but as it stands, we're still heavily relying on the TR velocity. So whenever you see a patient in the clinic with the clinical suspicion of a pH and subjective assessment, including shortness of breath, reduction in exercise tolerance, evidence of fluid overload, they have to be referred to the echo clinic if they've got a high NT-proBNP for the assessment of a pH, and having a TR velocity of more than 2.8 and certainly more than 3.4 raises a suspicion of a pH and high probability of pH. So in this, the case which I'm going to present to you is basically a 47-year-old male who was referred to our center because he was getting short of breath for the last 6 months. When he was seen in our center in Sheffield, he was significantly fluid overloaded. He had a very reduced exercise tolerance. So he had a bit of a complex background. He was already on immunosuppressants because he's had 2 previously failed renal transplants. He did also have underlying lung pathology. He was suffering from COPD because he was a long-time smoker, and he suffered from hypertension. His ECG demonstrated some features of RV strain. He did have a right axis deviation. There was some evidence of right ventricular hypertrophy. We usually tend to perform a VQ scan and or CTP in our center just to exclude any underlying chronic thromboembolic disease. There was no evidence of a PE. Test CT understandably showed some evidence of mild emphysema. However, there was some evidence of severe airflow obstruction pattern on the lung function test with the FEE or FEC ratio of less than 30%. So this was his echocardiogram on the index presentation. As you can see, that the RV was severely dilated with impaired function. There was a significant reduction in the TAPC. There was elevation of the systolic pulmonary artery pressures. There was evidence of a dilated IVC with evidence of pericardial effusion. And also you can see that there was a flattening of the interventricular septum throughout the cardiac cycle, suggestive of raised volume as well as significantly volume and pressure overloaded ventricle. Understandably, with this suspicion, with this echo, the patient was then referred for the right heart catheterization in our center for the estimation of cardiopulmonary hemodynamics. Understandably, judge showed slightly elevated right atrial pressure, but significantly elevated systolic pulmonary artery pressure. The wedge pressure was less than 15, which was suggestive of a precapillary component there. And then the PVR was significantly elevated, more than 3 Wood units, and in this case, it was 12.3 Wood units. He was unable to perform a shuttle walk test because he was that symptomatic. So based on the history and assessment, understandably, this patient did have a pulmonary arterial hypertension, but because of his comorbidities, he fell into these 3 categories or 3 groups. So group 3, which was lung disease, and group 5, which was understandably caused by his advanced renal disease because he was dialysis dependent. So if you look at the ESC criteria, in this group of patients, whereby they've got underlying lung and renal pathologies, the treatment strategy is not well defined, and they basically recommend having a consensus within the center to basically go down the route of individualized approach. So therefore, it was discussed in our MDT, and this patient was then cautiously started on 2 strong vasodilators, including sildenafil and macitentan. And then we always tend to arrange follow-ups with these patients with ECGs, NT-proBNPs, walk tests, and as well as echocardiograms. Sometimes we do tend to combine cardiac MRIs as well, just for diagnostic and reassurity. And this was his echo at 9 months. You can see there was a dramatic improvement in RV function and size. The TAPC had almost gone, it was still low, but there was some mild certain improvement. There was a significant improvement in the systolic pulmonary arterial pressures. There was no evidence of pericardial effusion on this occasion. And also you can see that the flattening of the interventricular septum was much better. And most importantly, from the patient's perspective, he was now able to exercise. So his incremental shuttle walk test, which was 0 on index presentation, he was able to walk to about 350 meters on this occasion. So at that very moment when he was seen in the clinic, we decided to continue to keep him on combination therapy with macitentan and sildenafil. And this is his most recent echocardiogram, which was performed nearly after 6 years of his index presentation. And you can see this RV function had remained stable. It's not dilated anymore. There's no evidence of pericardial effusion. And most importantly, from the patient's perspective, subjectively, he's been still able to perform a very good shuttle walk test. His exercise tolerance has remained stable. And his last incremental shuttle walk test was concluded at 460 meters. So we decided to continue to keep this patient on vasodilator therapy. So understandably, there were some obviously learning points from this case report that the diagnosis and classification of PH requires a very systematic workup, understandably performing a lot of investigations, including cardiopulmonary hemodynamics, and as well as echocardiography. Now, in this group of patients whereby there is a diagnostic dilemma in terms of, yes, you have a patient with a high PVR, but they have also got underlying lung and renal pathologies, the ESC recommends an individualized approach in tertiary care center in our patient. So therefore, we have demonstrated a patient who's a long-term responder to a vasodilator therapy. And I can say with certainty that echocardiography can be a very good follow-up tool to basically try and monitor these patients in the longer run. So thank you.
Thank you so much. Medicine works, doesn't it? It's amazing. So our next case presentation is going to be from Dr. Aleksandra Sustar, who's going to speak to us about the role of RV and PA coupling in precapillary pulmonary hypertension with preserved LV function. Thank you so much.
Hello to everyone. My name is Aleksandra, and today I want to answer the following question. Can we spot early signs of right ventricular stress in COPD-related pulmonary hypertension? So this is a story about 67-year-old woman. She is a heavy smoker, and she has been diagnosed in 2024 with COPD Gold 3. Her past medical history includes paroxysmal atrial fibrillation, hypertension, and dyslipidemia. And she is taking her chronic medications appropriately. Her main symptom in 2024 was progressive exertional dyspnea and fatigue. So her initial diagnostics findings from 2024 includes NT-proBNP of 246. Echocardiography revealed preserved left ventricular function, no relevant valvulopathies, no relevant diastolic dysfunction, and right heart seems a little bit larger than left heart. TAPSE was almost 20, SPAP was measured 99 milligram, and TAPSE over SPAP ratio 0.20. The right heart catheter in 2024 confirmed precapillary pulmonary hypertension. And we had a diagnosis of COPD patient with disproportionate pulmonary hypertension. The therapy with tadalafil and oxygen has been started. So she came to me in March 2025 for a follow-up, and she was on tadalafil and oxygen since January 2025. In 6 meters walking test, she achieved 71% of predicted. It is about 345 meters. She is slowly reducing smoking, and as we can see, NT-proBNP has been reduced to 176. TAPSE over SPAP has been improved to 0.29, but strain and TAPSE remained preserved. So visually seems unchanged, but mechanically improved. In May, she came to me occasionally for a follow-up, and then TAPSE over SPAP ratio has been measured, and it was 0.29. TAPSE and strain preserved, NT-proBNP unfortunately not rechecked, and she continued the therapy with tadalafil and oxygen. So she was referred to Pulmonary Hypertension Center. So these are echoes from 2024, from March and May 2025, just to show you that they seem quite similar. So left ventricular function is preserved, right ventricle seems a little bit bigger, TAPSE and strain are in normal range, but actually the hidden stress has been revealed by TAPSE over SPAP ratio. What are the trends? So TAPSE remained more or less in normal range, SPAP has been reduced, TAPSE over SPAP has been improved, and NT-proBNP has been reduced under tadalafil and oxygen therapy, but I think that was not enough. This is a graph that shows the same, so we have a TAPSE over SPAP ratio that has been improved, but still not in normal range. So how do we act on it? And this is only my proposal. So according to European Society of Cardiology and guidelines, the cutoff is 0.55. So then the interpretation of this value is normal coupling. And when we have a patient with more than 0.55, that means we should monitor the patient routinely in 6 to 12 months. But if we have the patient who has values less than 0.32, that means bad interaction between pulmonary vascular pressure and right ventricle. So that means that we have to escalate pulmonary hypertension therapy and add oxygen. And of course, refer to Pulmonary Hypertension Center. So why it matters? It matters because TAPSE alone may overestimate RV function, but TAPSE over SPAP ratio detects early mechanical stress and reflects RV adaptation to afterload. So take home is that this marker is a simple non-invasive indicator of early RV-PA uncoupling, and it detects mechanical stress in COPD PH before NT-proBNP rise or over dysfunction. And remember to measure coupling and not comfort. Thank you very much for your attention.
Thank you so much, Dr. Sustar. I think in the interest of time, and I think a lot of people are very much needing some coffee this morning, we probably will just move on to the coffee break now, and our speakers, I'm sure, will be very glad to take questions if you go and find them over coffee. Thank you.